Can I stop it now?
viruses, parasites, and fungi. These
Now let the video run once on your system because it is buffering. So let it run on your system once, but you can switch it off the screen.
the year is 2064.
That is not because
Our
of the,
last
it's all
line
because
of
of the
defense
Wi-Fi,
is
how much
faltering.
the strong connectivity and
Mankind's
Okay.
all the video kind of buffers
Yeah, we
for
can
some
stop it.
time.
It's 9:30 already.
It's not a smooth play. We'll wait for few minutes, sir. Chokhani, sir.
No, I think yeah, it's 9:31, so maybe 1 or 2 minutes we can wait.
Yes, sir.
I think we can put that message in the zones that we are starting. Can you just put that message, Shika, that we are starting so that people. Hi, Jagruti.
Hello, how are you, Samir? Congratulations on the Baroda opening.
Thank you.
That's really great news. Hello, sir, Dr. Chokani, Dr. Kasla. Hi, Shikha.
Hi.
Hello, madam.
Hello, Danya
Dr.
ma'am.
Daniel, hello, good evening.
Hi, Rajesh bhai.
Good evening
Hello.
to all.
Good evening.
We start, I think.
Samir, sir,
Yes.
shall we start?
Yeah. Whatever Rajesh bhai says, we can start.
Sir just said that.
Okay.
Okay, so good evening, everyone, and a very warm welcome to everyone to this online session, which is an extension of the academics that we had at Navi MBCon. And I would like our conference convener and another convener of the online sessions as well, Dr. Samir Dalwai, sir, to please give the idea behind the whole online session for this.
Thank you, Dr. Shika, Secretary IAP Mumbai and Indian Academy of Pediatrics Mumbai branch is always known for being the innovator. And I thank Dr. Rajesh Chokhani, sir, Dr. Nehal, who's not here today, but Dr. Sikha, Dr. Rajesh Kasla, and Dr. Amruta, who are the brains behind this entire idea to continue the conference because the CME means continuing medical education. So it should not be stopping with the conferences, it should be continuing. So they had this idea that we must take the most important or the most well attended sessions of the conference And in the conference, unfortunately, only a limited number of speakers can get the opportunity to share their knowledge. But there must be an opportunity for everybody else in the organization also to share their knowledge. And with this in mind, we have two experts today, Dr. Rajesh Chokhani and Dr. Dhanya, who will be sharing their knowledge. So this was the concept. And the topic, of course, is the most important, you may say the bread, butter, and also the jam of pediatric practice, infectious diseases. And in infectious diseases, things keep changing, new things are being discovered. But today on a public health platform or a public health policy platform, I think the most important, most striking issue that is affecting all of us is antimicrobial resistance. And the Indian Academy of Pediatrics at the central IAP level has started a program called IAP Ki Baat Community Ke Saath, which takes the message from the pediatricians to the community. Because unless we involve the community, our organization will not serve its purpose. And they did a session on antimicrobial resistance, and they have come up with a video, which I shall request with the permission of the chair, our host to play that video. इसे गौर से देखिए because this is being sent to you. It can be sent to you now also. Please share it on your social media platforms, on the TV, in your clinic, etc. Can we have that video, please?
Screen visible, right?
Yes.
Yes.
Strongest weapons are failing. A group of weary soldiers approaches an old wise woman for advice. She listens carefully and begins to narrate the history of antibiotics. There was a long time ago when human life was fragile and microbes ruled the world. Human lifespan was short, barely 35-40 years. Long ago, then great scientists discovered the world of microbes, bacteria, viruses, parasites, and fungi. These scientists created antibiotics, the weapons that saved humanity. What are antibiotics? Antibiotics are medications used to treat infections caused by bacteria in humans and animals. They either kill the bacteria or prevent them from growing and multiplying. Antibiotics do not work against viruses. But over time, people misused and overused this weapon. They used antibiotics even when they didn't need them, like for viral infections and use of unprescribed over-the-counter medicines. What are viral infections? Viral infections are illnesses caused by viruses, which are small germs that use your cells to reproduce. Some common viral infections include chickenpox, influenza, hepatitis. Antibiotics do not kill viruses, yet they were used recklessly even for viral illnesses. This misuse led to the rise of a new enemy, resistant microbes or AMR, antimicrobial resistance. Antimicrobial resistance occurs when bacteria evolve and become resistant to antibiotics. This makes infections harder to treat and increases the risk of severe illness and death. Superbugs are bacteria that have developed resistance to multiple types of antibiotics, making them extremely dangerous and hard to treat. Consequences of AMR are increased severity of illness, prolonged recovery times, extended hospital stays, higher treatment costs, and risk of death. These superbugs are now a threat to the entire world. How did antibiotic resistance develop? Antibiotic resistance develops when bacteria are exposed to antibiotics and some survive. These resistant bacteria multiply and can pass their resistance to other bacteria. When antibiotics are used unnecessarily, like for viral infections, they help create antibiotic resistant bacteria. What can be done? For this, you have to go back in time to 2024 and meet doctors from the Indian Academy of Pediatrics. In India, the Indian Academy of Pediatrics is leading the charge against antibiotic misuse. They are helping protect children and families by raising awareness and promoting responsible use of antibiotics. To fight AMR, the Indian Academy of Pediatrics advocates use antibiotics only as prescribed by a doctor. Complete the full course of antibiotics even if you feel better. Never share antibiotics or use leftover prescriptions. Don't take antibiotics for viral infections. Practice good hygiene to avoid infections. We must use antibiotics responsibly, only when needed, and always as directed. The war against antibiotic resistance is far from over. But with knowledge and responsibility, we can still win. Use antibiotics judiciously. Prevent antimicrobial resistance. Learn more from the Indian Academy of Pediatrics. Produced by IAP की बात कम्युनिटी के साथ. Creative Director Dr. Sameer Dalwai.
Thank you, Dr. Shikha. And I request you to put this video, you can share it in the chat box so people can download it and share it on their own social media. It's over to Dr. Shikha to take the event ahead. Thank you so much.
Okay, thank you so much, sir. So with this beautiful animated preface setting the tone of our session, so we'll start now the most awaited academic session. And to enlighten us on this topic further, we have two very eminent speakers. First is Dr. Dhanya Dharmapalan, who is a senior consultant in pediatric infectious disease at Apollo Hospital, Navi Mumbai. And second is our own Dr. Rajesh Chokani, sir, who needs no introduction. So, and to moderate the session, we have our president from IAP Mumbai, Dr. Rajesh Kasla sir, and also Dr. Sameer Dalwai sir, who would be guiding us through this. I request all the delegates to take full advantage of this situation and put as many questions as you have on the chat box so that the discussion can be taken forward. Over to you, Kasla sir.
Okay, can I share the screen? Sika, thank you for the introduction. Can I share the screen?
Yes, sir. Please check if you are allowed for that.
Is my screen visible?
No, sir.
No. Then I think you will only have to do it.
Nilesh sir is allowed for a screen share, right? Nilesh, are you there?
Yes, madam.
Yeah, I'm trying to do that.
You are a co-host, Rajesh.
Yes, I'm trying to do that, sir, if it is possible.
We can see your
Now?
this one now. I
Now?
think the screen.
Now?
Yes, you can
It's
see.
Yes, sir. Now you go full screen now.
Yeah, I'm full.
Screen.
I am full
It
screen.
is full screen. Please go ahead. You are set.
Okay.
Yes, sir.
So thank you, Dr. Sika, for that introduction. And without wasting much time, I will straight away go to the science because we are already 15 minutes into this seminar. Yeah, I would request all the participants to put the question in the chat box. We will try to have more interaction. We will try to solve all the unanswered queries which are there in that brainstorming session, which was recently concluded the Navi MBCon. And I will try my level best to have minimal repetitions, but the cases which are there are going to be discussed in detail, and we'll try to come up with the new things which were not discussed in the scientific session there. So friends, since 1970, almost 40 new infectious diseases have been added to our armamentarium. And in 2007, WHO had warned us about the speed at which these emerging infections are going to create trouble. And in 2018, WHO reiterated that these emerging infections are going to be, they have the potential of causing public health emergency. And 2020, the COVID struck, and the rest of the history. So we straight away move to this topic of emerging and re-emerging infections. So my first question to Dr. Dhanya, madam, how exactly do we define what is the meaning of emerging and re-emerging infections?
So emerging infections are infections which were unknown before. Like when the pandemic happened, nobody knew about the novel coronavirus. But when you say re-emerging, they are infections which were sort of controlled, which were not present for a specific period and then suddenly start emerging. It may also mean that a particular location does not have that infection, and then that location starts seeing it. For example, how dengue spread from urban to rural. So when rural areas were not seeing dengue for them, it was emerging. But if, like, say, malaria was under control, falciparum in Navi Mumbai, and then suddenly if there are some cases, it would be re-emerging infection for Navi Mumbai. And the third point is, in case the infection has presented in an unusual manner, like what, for example, hand, foot, mouth disease, classically distributed on the hands, feet, and the mouth. But uh, I mean, if you're seeing on different areas, you wonder what's happening. So something different in the clinical practice that you're seeing, you would need to know whether it's a new infection emerging or something has happened to the pathogen. So I would classify all this. Dr. Chokhani,
So
would you?
can we, Dr.
No, I think I agree with all that she said. So please go ahead.
Yes. So you gave few examples of malaria and hand, foot, mouth disease. So can we just enlist that what all infections are enlisted as emerging infections?
Yes, so I talked about common infections, but we know that WHO recently had declared Mpox as a global health concern. And so that's an emerging infection, or rather re-emerging infection in the global context. We have heard about Nipah, which affected some state, especially Kerala in India. So that was an re-emerging. Thank you for putting this on the slide. But all these Ebola, Zika, we recently, I mean, I'm giving examples so that you can connect. Like Pune had this outbreak of Zika recently, and more recently, there was a huge outbreak of chikungunya in certain areas of Maharashtra. So all these would classify. We had seen in Mumbai and several cities in India a huge outbreak of adenovirus, which had actually, I mean, it was a pretty huge outbreak. So, I mean, something that you would agree with me that in your clinical practice of several years, you had not seen this proportion. So, um, plus, Dr. Khalsa has enlisted the multi-drug resistant, and thank you, Dr. Samir Dalwai, for the beautiful video on AMR, so essential. Drug resistance, changing pattern of the susceptibility is definitely an ongoing menace that is happening in the field of infectious disease, and that's also a dynamic emerging infection.
Dr. Chokhani, sir, your comments as a practicing pediatrician for more than 3 decades, how has the morbidity pattern changed of these infectious diseases? Are we encountering these diseases that commonly? Of course, dengue and hand, foot, mouth disease has been rampant for the past few years. But those others which have been listed, your comments on that?
I think the morbidity patterns keep changing. For example, when either because when dengue, we first started treating dengue some 15, 20 years back in a big way, we were all petrified and we used to lose a lot of children and things like that. That scenario seems to have changed now, whether we are better trained or whether the clinical pattern of the virus has changed. It could be both. Similarly, in typhoid, nowadays the only thing that we see is that the fever just goes on and on and on. But complications from typhoid or death due to typhoid is kind of almost uncommon in clinical practice. On the other hand, tuberculosis is getting from bad to worse. I mean, we are not able to, tackle it, and the number of MDR, XDR cases are on the rise. So what I mean is that the patterns, clinical patterns that we see keep changing, both agent related, host related, because some of these manifestations are immune mediated, and environment related. So all three factors will affect the clinical pattern.
So, madam, my next question is, what is the reason of this increase in this infections? What is the cause?
So to talk about the reasons, if you go back to your previous slide, please. So if you see most of the emerging or re-emerging infections that we know of, most of them are viruses. And why so? Because the essential pathogenesis of virus is that they multiply in a living cell. I mean, a bacteria doesn't require to do that. So what happens is the virus injects its genetic material into the host cell and then also uses the resources of the host cell and then replicates. And so that is a part of evolution also, and that is how the viruses also jump from zoonotic, I mean, the animals to human species, especially in the context of a closer contact with the wild animals. So if you see, many of these emerging infections are also from animals, like, for example, whether it is Nipah, which is from the bat, or whether it is, I mean, we know HIV was from a chimpanzee. We know that MERS, SARS, there was contact with, I mean, camel contact is important, or whether I mean, so many infections, SARS coronavirus. So SARS corona was not from an, I mean, was from wild, I mean, wild bat from the market in China. So actually, if you go to see, 80% of these new emerging infections are from animals, and the closer we kind of encroach into their territory, because of urbanization, because of agriculture, because of, so I mean, because of human activities, basically we are responsible that we are having more of these zoonotic infections. Now, climate change is also extremely important, because there's a lot of talk on climate change cause in infectious disease field, because many certain areas where there was no malaria, they have attributed it to climate change for the increase in malaria. You must have all heard of the drug-resistant fungal infection called as Candida auris, which is also reported from India. So that is again, I mean, there's this hypothesis. It is the climate change that has caused this increase globally of Candida auris. Increase in international travel has actually helped in transmission, faster transmission of infection geographically. So that is why, even if like the Mpox is reported in Africa, the moment it was declared a global health emergency, we had guidelines from the government to take history of contact of people arriving from that country and look for these symptoms. It is because of, I mean, it's so easy that from infections to spread from one country to another. Reduction in vaccine coverage, we have seen during COVID pandemic. There have been increases in infections post-pandemic because of the reduction in vaccine coverage. And of course, AMR, we have already talked about. Now, the first point, spontaneous mutations, the viruses are more prone for bacteria than bacteria, but it is not that bacteria are not prone for spontaneous. Of course, they are. I'm just giving an example why viruses seem to be more common in having spontaneous mutations.
Okay. I think with this background, we shift to our cases. And sir, Dr. Chokhani, sir, I will begin with you, because we are the pediatricians who face these cases. And then when we are confused, we take the opinion of the infectious disease consultant. So we had this 23-year-old primary mother without any significant antenatal problems. She delivered a normal baby, full-term normal delivery. The child had some perinatal asphyxia, was in HI stage 1, but subsequently discharged on day 7. And this child came back at the age of 1 month with fever, vomiting, loose motions, and irritability since 4 days. And there was this rash, the vesicular rash, which was seen on the right arm and the anterior abdominal wall on day 2 of the illness. So, with this presentation, uh, on clinical examination, the weight, the length, and the head circumference was within the normal range. There was some dehydration. Fontanelle was normal, and this vesicular rash was seen. Systemic examination was normal. So, basic investigations was done because the child was 1 month, had come with fever, which showed severe thrombocytopenia, and SGOT was raised around 115, and there was hypocalcemia too. So, a third generation cephalosporin was started, and the supportive line of treatment was started, and one random platelet transfusion was given. Blood culture also was sent. So this was on the first day at the time of presentation. Subsequently, what happened was day 5, day 6, this child had this post-inflammatory type of changes on the skin, and the peripheries had become cold and the child had become irritable. And on day 6, this child developed a seizure, eventually went into a shock, requiring inotropic support, and the antibiotics are upgraded to carbapenems, and levetiracetam was given for the seizures. CSF study was performed, which was the cellular morphology and the biochemistry was normal. So, sir, what would you think as a diagnosis? I know I have given you the whole picture, including the investigations. I did not stop at the clinical picture, but with the lack of time, I think we'll have to.
I think when we start with the clinical picture, I would have said that this is some infection. But if it's an infection in a 1 month old baby, my first thing would be, is there any contact in the family and whether this is a viral or a bacterial infection? Of course, in a 1 month old baby, you start presuming it is bacterial sepsis unless proved otherwise, then bacterial infections. But there were some odd points in the story, as in you said, 4 days of fever, vomiting, loose motions, irritability. Usually, a bacterial infection in an infant would progress fast. So I would have expected this bacterial infection to have got much worse within those 4 days also, but this could well be a hindsight. So I think the treatment, I mean, presuming that it's a bacterial infection is fine, giving cephalosporins is fine. The investigations are not very discriminatory. Thrombocytopenia and any kind of transaminitis is known in any infection at that age. So it would not really discriminate between the two. The surprising part is the worsening around day 5, day 6. So the baby going in clinical shock on day 5, day 6 is a little unusual. I'm presuming that for the first 4, 5 days, first 4 days which you said, the baby was not treated with any specific medication.
Yeah.
So I am saying that in the timetable of the illness, for a bacterial infection to worsen on day 6 in a 1 month old neonate is a little odd. So I can only say clinically that I am dealing with something unusual, but what is that unusual, I don't know. So I will have to support this baby in multiple ways, continue antibiotics till I rule out a bacterial infection convincingly, or label it as something else. I mean, I get positive evidence for something else. So that's the stage I am in right now.
So, madam, your comments. I mean, beyond bacterial infections, are we suspecting with this rash, which is vesicular rash followed by uh, post-inflammatory changes?
Yes, so at present, I would completely agree with what Dr. Chokhani mentioned, that at this point, what is to be noted is that it's not behaving exactly like a bacterial infection. It could be some other infectious conditions, and I would continue with the same supportive treatment at present and keep investigating, look at contact history, whatever Dr. Chokhani said.
Yeah. So, I mean, what further investigations can we ask for? By this time, the blood culture had come, which was not showing any growth.
So
Yes.
Rajesh, all kinds of viral infections, I guess at this age should be, we should get a history of a contact in the immediate close family. So there's a question about varicella also on the chat. So
Yeah.
I thought that for all viral infections, I should have got a history, and that's why we don't have that kind of a history,
So
right?
there was no significant antenatal history, which I mentioned in 1 month also. No significant history of fever in the mother or immediate contact with the family members.
And if you go back to your slide, the initial rash that you showed, so what's
Yeah.
important to look at it is that you notice that they are vesicular, fluid filled. And when you have fluid filled, if in a suppose it's a baby who is absolutely healthy with no systemic signs, then you look at contact dermatitis, you look at congenital bullous conditions. But here is a child who is sick with this kind of vesicles, and you look closer at the lesions, you find there is no erythema around. Now, in this, when you have erythematous surrounding, generally the bacterial infections, which we know, which will come with vesiculobullous lesions like staphylococcus, they do have some erythema. So that's why you think more in terms of viruses. Now, viruses, what can cause is even varicella. Then you look for, is there a pleomorphic kind of a distribution that you usually see in varicella? Or is it like HSV where the vesicles are small? Because in one of the, was there a slide with little large bullets? This
No,
was,
these are
yeah.
very small vesicular-like
Okay.
lesions.
So HSV can be one, but they come in small clusters. But this kind of pigmentation that comes can come with some viruses like say chikungunya, where you have
Yeah.
hyperpigmentation. So you need to kind of look at all that.
So, madam, as you said, the chikungunya IgM test was done on this baby and it was proved to be positive. So that opens the Pandora's box that if this child had chikungunya IgM positive, was it a congenital chikungunya or acquired one? And how do we differentiate into that?
So at 1 month of, yeah, sorry. Can I?
Go ahead, Dhanya.
Yeah.
1 month, at 1 month, I mean, it can be, it is mostly acquired at 1 month. If it had been few days of age, what you could do is you can check in, you can take history in the mother, you can send IgM in the mother and check. Many times, in fact, even if the mother has clinical signs, but at 1 month they both could have been affected together. So you have to relate it with the delivery time. And I mean, and I don't think at this point whether it is congenital or acquired will change the management per se.
So any other investigations that were required? I mean, so this is a typical child who has come with fever, a skin rash with hyperpigmentation, and encephalopathy-like picture. So yes, chikungunya is one on the list. Any other viral infection is known to cause such a picture, which we should be aware of?
So I gave a differential of HSV. I gave a differential of, I mean, but then HSV doesn't come with the size of the bulle that chikungunya can come, and the chick sign is very classical with chikungunya, the brownie nose that we say, especially in the area of the face. That's very classical for chikungunya. I don't know if I have missed anything.
Okay. So here, as you said, since the child was 1 month old, there is no need that we should do the maternal chikungunya titers because mostly this is an acquired type of infection. So does the prognostication change if it is congenital or acquired?
Prognostic, if the I mean, if you're asking about whether the maternal antibodies will
Yes.
protect but not
No,
very
no.
close to the delivery.
What I mean is that if suppose this baby would have been within 1 week of life mother's antibody was positive and this child had neonatal chikungunya versus the child who has acquired at 1 month. So does the prognosis change?
In general, I would think that if it was acquired from the mother intrapartum or just before that, it would be worse,
Yeah.
is what I would think in general. Secondly, I mean, as a general pediatrician, I would say, as Dhanya said, that vesicular lesions are seen in many viruses. So, till you get the hyperpigmentation, I'm not sure whether you are led towards chikungunya in the absence of a contact history. Hyperpigmentation narrows down our vision definitely, and we are more towards chikungunya. But that was my thought that till you have just vesicular, you are open to many viruses, even with encephalopathy.
Okay. Okay. So then we move forward. So the important message that we learned from this case was that when we face a clinical triad in newborn age group, where there is fever, hyperpigmentation, and encephalopathy, then we should definitely have, with this background epidemiology, we should definitely think about chikungunya as this. Sir and madam both, what about Zika virus? Can Zika virus present like this?
So Zika, importantly, if it is in the early part of pregnancy, we know that it is associated with microcephaly. But towards the later, I mean, towards the end of the pregnancy, I'm not sure, but not like this, not like neonatal chikungunya.
All right, all right. Okay, so in this complex matrix of neonatal infections, so we have one more addition now, chikungunya. We'll have to keep that in mind that it can come up. So we move to the second case, sir. We have a 10-year-old boy with high fever on the first day and this viral exanthem. There was no localizing sign for fever except for this viral exanthem. And the fever subsided by 4th day and the rash worsened by day 5. So this rash is on day 5 of the illness. With generalized body ache and difficulty in getting up from the sitting position. So we see most of these cases in the OPD. So sir, what would
As a general approach, I would like to ask a few questions about the few details about the fever. So you said high fever on day 1, but how did the fever behave on day 2, day 3, day 4? I would like to know, because that will. So my approach in a febrile child in the OPD is to begin with whether I'm looking at it as a viral infection or a bacterial infection. So I need some more details about the fever. For example, when we are talking of this kind of a rash, the timetable of the rash is also important. So for example, in dengue, the rash is likely to come up a little later. In a situation like a scarlet fever, you can get a erythematous rash very early and you will have associated pharyngitis, throat pain, etc. So the sickness of the patient, the timetable of the rash, the behavior of the fever, these two things will broadly make me decide whether this is a viral infection primarily or a bacterial infection like a streptococcal scarlet fever. And then, of course, the progress. So you said that on fever subsided on day 4 and then generalized body ache and difficulty in getting up. So this kind of a picture on day 4, day 5 is more like a post-viral myalgia, which we see in dengue and many other viral infections.
so the investigations were done on day 5. It did not contribute much. The hemoglobin was normal. Malaria was negative. Dengue, NS1 and IgM also was negative. So further on by day 10, this child developed pain in both the hands and feet and was unable to walk due to pain. This was on day 10.
Now that the pain is shifted to feet and hands, I mean, I'm presuming that now it is kind of joint pain. So when we talk clinically, we have this fever and musculoskeletal pains coming together as various viruses. But if we were to split hair between chikungunya and let's say dengue, in chikungunya, joint pain would be plus 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 arthralgia, whereas in dengue, myalgia would be plus plus. So if this foot and hand pain is to be taken as joint pain, then I am moving slightly towards chikungunya as a clinical diagnosis. Especially it is happening on day 10, as in the acute phase of chikungunya is known to last longer. So these are the subtle clinical differences, like you have listed Zika. So in Zika, there may be more prominent rash and some amount of conjunctivitis, whereas the pains are not as prominent as chikungunya, dengue. But this all we talk when we are talking of three different patients and trying to say in this patient this is more, in this patient this is less. But in a given patient, all three would be possible. You will just have to put down, probability number 1, 2, 3, something like that.
And I feel it's very important to, I mean, apart from what has been said, that it's not just the skin rash. You look into the eyes, you look into the mouth, because there are several. I mean, for example, I'm just saying, say Kawasaki disease, which can come in with arthritis and the history of pain in the joints. But of course, the fever would go on. You would have a strawberry tongue. You would have congestion, eye congestion, which may have a perilimbal sparing. So basically, it's not just the skin. I mean, you need to look at other areas also. This is just to add on.
Yeah. So with that, further the investigations was done where they did ESR and CRP, which was again slightly elevated. So since the dengue was already ruled out in the first 4 days of illness, further this child was tested for chikungunya, and here chikungunya IgM ELISA came positive. So now my question is that what are the clinical differentiation in chikungunya between children and the adult age group?
So, as you projected, the bullous rash that we see, or skin changes like pigmentary changes, are more seen in the children compared to adults. But recently, in the Pune outbreak that we had, many adult ID people were baffled with the sheer increase in number of adults who had pigmentary changes. So this is not a rule; it's just a proportional differences. And oral ulcers are found to be more associated with adults. And in fact, adults may have longer durations of severe arthritis. But at the same time, we have had, I would talk about the recent experience that Pune colleagues had and the adult ID. They saw a lot of unusual cases of neurological involvement in adults. Though we see that it's more in the children as per the chart, but they had seen meningoencephalitis and such features, even neuropathies. So, the infections are dynamic. We can have different presentation, but when we kind of discuss with the ICMR scientists in Pune about what's actually happening, what they mentioned is that the virus has not changed, doesn't seem to have changed. There is a rapid task force that has been set by Maharashtra government to investigate the outbreak in Pune. But provisionally, what they have said is it's just because the sheer denominator, the number of chikungunya cases that went up, that we feel that it's some different strain of chikungunya, but it seems to be the same. That is why the unusual manifestations seem to have increased. It's just the denominator that has increased.
So in such given cases, does any laboratory parameters help us to differentiate between dengue and chikungunya, which is the closest diagnosis?
So early in the illness, it would be PCR, and it is highly recommended to test both dengue and chikungunya together. I mean, it would be more, of course, challenging when Zika is also being seen in the same city. But later on, it will be definite IgM positive. Ideal, it would be after 6 days. But they have reported, even ICMR scientists have said that it has come early positive also. Now, IgM also, you have ELISA and rapid tests. So it would be ELISA that would be preferable.
Yeah. Dr. Chokhani sir, before we go for this serological test, any clues that we can get from the simple complete blood count about the differentiation between these vaccines?
Personally, I feel that between them, differentiation from CBC or CRP or all these inflammatory markers is not going to be dependable. So it will have to be the clinical profile only, because theoretically we can say that okay, lymphopenia favors chikungunya or neutropenia favors dengue, but all these are, they depend on the stage at which you do the CBC in the illness, day 1, day 2, day 3, day 4, and so many other things. So I think in a given patient we cannot depend on this. uh, we can to some extent separate clinically, otherwise we can't. But I have another viewpoint which I would like even Dhanya to comment on. I would rather uh, talk of it as a, as a viral versus a non-viral illness or a bacterial illness is my first uh, worry as a clinician. And the second is, if it is a viral illness, is it severe or like uh, serious or non-serious? So if it is a non-serious virus illness, does it make a big difference whether I should separate out which virus it is? And or I can clinically, because the treatment is going to be the same symptomatic treatment for all. So do I need a black and white diagnosis in non-serious cases from the labs, be it anything in the labs? That's the viewpoint I have. Comments are welcome.
So I would say that, say for example, dengue, we definitely keep a close watch. We are so much familiar with the dengue complications that can occur, and I mean, but if you're saying, like, say for example, Zika may not be kind of, the management will not change, but if you are considering many cases that you see are not really, I mean, you have kind of a doubt whether it's Zika. It is important from an epidemiological point of view, because you have pregnant ladies, and if for public health point of view to report or investigate. But otherwise, for individual, it's again clinical and clinical management.
Sir, I may just add that the difference is because dengue itself will cause immediate morbidities, while chikungunya, the morbidities is a bit prolonged and it is milder morbidities as compared to dengue.
No, I agree. My point is, I am seeing a child on day 4, day 5 of the illness, and I am between a mild dengue versus a mild chikungunya. So how will these investigations help me change anything is my question. And I mean, all these, don't you agree that all these CBC parameters are non-specific, as in there's no heavy tilting to one side. So I
Yeah.
can't depend on that. That was my point.
Yeah. So we move ahead. Next slide. Okay. Yeah. So my next question, madam, is about the management of chikungunya. What medications can be used and what are the preventive measures for chikungunya? I mean, the public health measures. And does these cases relapse later after a few months?
Medications are mainly supportive, and I mean, for fever management for any viral, for that matter, it's always paracetamol that should be preferred. But in case there's severe joint pain and you want to kind of use some NSAIDs, you should avoid any kind of an aspirin in a viral infection, and which can also cause hemorrhage in such make it more vulnerable for hemorrhagic complications. So ibugesic is fine, but again, these viral I would always paracetamol is always on the top. Steroids, well, steroids, there is a lot of controversy regarding the use of steroids. If you're talking of chikungunya, maybe in a severe joint condition, but not early on, definitely when there is viremia, unless you are seeing something which the virus has caused, say an HLH or MIC type of. In fact, there are some reports from Southern America where they have seen MIC related to chikungunya. But otherwise, I don't think so. I think we have Shika here on the panel who would be a better person than me, and she can comment. Physiotherapy, definitely. Shika, are you there?
Yes, I'm there, but exact question I couldn't understand.
The role of steroids in chikungunya.
Before Shikha comes in, I would like to say something as a general pediatrician. So when it comes to steroids in chikungunya, let us understand that there is no clarity. So chikungunya clinical treatment is in the acute phase, the acute illness, which you can say is usually 10 days but can go on till about a month. Then you have a period which is post-acute, 1 to 3 months, and then you have chronic symptoms which are beyond 3 months. The point to understand is that there is no clarity whether steroids used after the acute phase, as Dhanya said, in acute phase, so we should not use. If you use after the acute phase, whether it will reduce or prevent further chronic complications, there is no clarity. So we should not be jumping at using steroids just in the hope that we will minimize future joint issues, etc. That is the message that I would like to give to pediatricians. Shikha can add now. Shikha?
That I completely agree with you. So we have seen patients which have been started on steroids, which should not be done, especially in the acute and subacute phases. It's only later, after 3 months, if you know that it's a chronic arthropathy, where only steroid is not the answer. A short course that time can be used, but not steroids in the first phase, like you have said. Absolutely agree with that thing.
Okay. So we move further.
Sorry, relapse, yeah.
Yeah,
Relapse
madam.
generally not, and prevention, of course, the mosquito, prevention of mosquito bites, I think everybody's aware of. Yeah.
Yeah, but I think as a pediatrician, we should be more proactive and anticipate and give more advice to them, because in this slide, especially when it is seen that most of these emerging infections are zoonotic diseases, and this Aedes mosquito is the one which is responsible for causing dengue, chikungunya, Zika virus disease and all. So prevention of the mosquito bite, the Aedes mosquito is very important. So the vector control measures are going to be the most important public health measure that can be taken. So, sir, as a general pediatrician, most of these patients who come to us, I think even if they ask or not, I think we should keep on advising them about the vector control measures, preventing mosquito bites, not only in the night time, because there's a tendency in people that mosquitoes bite only at night, and so
it's daytime as well, and indoors and outdoors both. So we need to tell them about all that. Yeah, definitely.
okay. So with that, we move to the re-emerging type of infection. So I'll go through it a bit faster. This is a 6-year-old boy who came with high-grade fever of 3 days. Again, high-grade, I mean 103 and above, with cough, vomiting, and throat pain. He had little congested throat with a tender cervical lymphadenopathy. So on OPD basis, this child was put on amoxiclav, a cough syrup, and paracetamol. But he came on day 5 with the fever, which is spiked up to 104.5. He was toxic look, and nothing on examination systemically. So X-ray chest was done and the basic blood workup was done. But the X-ray showed this right middle zone pneumonia and the CRP was 47.7. Now here, this child was hospitalized and started on second line of therapy because amoxicillin clavulanic acid was given. This child was put on ceftriaxone. So should we continue with this line of treatment or any other further test needs to be done at this stage? Is my question to you, sir.
So actually, again, clinically, if we go, you said that right in the beginning, you said cough. Now here we are looking at a kind of a lobar consolidation. So usually these lobar consolidations come with high fever in the beginning, but the cough is not prominent in the beginning. So if this child was genuinely coughing a lot right from the beginning, and I find this lobar consolidation, that extra cough gives me a clue that this is an infection which is transmitted or mediated through the airways. So that makes me shift my etiology from the usual bacteria like strep pneumoniae, etc., to something like a atypical mycobacteria, so mycoplasma, chlamydia, etc. So I think this is a very important clue that we clinicians should be looking for if you have to differentiate between these etiologies. And plus, of course, this is an older child, so that also fits in with a possible etiology of a atypical organism.
So as you said, sir, another thing was this during this time, this was just few months back, when there was a sudden surge of mycoplasma infection. So multiplex PCR test, throat swab, nasopharyngeal swab was done, which shows that the mycoplasma was positive in that. So my question is that whether this was the right thing to do or whether a mycoplasma IgM should be done. And of course, once the mycoplasma came positive on this throat swab, the child was put on azithromycin for 5 days. Then X-ray test was repeated where there was hardly any difference in the on the X-ray. The patch was almost persistent, remained the same. So what should be the line of treatment here?
Answering your first question about whether IgM or PCR is always better, as in it is more sensitive, specific than IgM. IgM will take time. It will come positive after 7-8 days of the onset of the illness, and there are other issues. So therefore, PCR is preferable. The problem is that many of these illnesses look clinically like viral illnesses. The counts will also be similar in a viral illness and in this. So it is not easy to separate out whether this is a viral infection or a mycoplasma. And mycoplasma asymptomatic infections are known. So my problem is that if I pick up a mycoplasma on a PCR, that itself is not good enough evidence that I am dealing with a mycoplasma in this child. It is supportive, but it's not like it doesn't stamp the process. So that is one. And the second is that after 5 days, you said he is not, X-ray is not better. So how is the child? As in, how is the fever? How is the
the
cough?
fever had subsided. The fever had subsided.
I think we always look at the clinical improvement first and radiological later. Yeah.
Madam, your comments on this?
There are a couple of things that IAP has given a very good clinical guideline for suspicion of mycoplasma, the RTI-GEM guidelines, where you have a subacute kind of presentation with perihilar streaking, where you have radiological findings disproportionate to the clinical. But the other situation is where you have extrapulmonary manifestations along with pneumonia. Again, you think of mycoplasma, whether it is hemolytic anemia or skin rash. The third is if there is no response to the usually used first line for the other bacteria, because we know that mycoplasma lacks cell wall and those antibiotics do not act, will not be able to kill mycoplasma. So the definition that IAP has provided are really excellent to go by. Regarding the test PCR, I would like you to go again to your the panel that you have shown. It's a very important message that I want to give out to everybody, that this is done on an upper respiratory specimen, whether it is nasopharyngeal swab or whether it is throat swab. It is to be used only for viruses and atypicals. Please do not rely on these reports for bacterial infections. If you want to check, they have to be essentially lower respiratory sample. So please, because a lot of antibiotic abuse takes place if one of the bacteria, like say strep pneumoniae, comes positive, and we know that strep pneumoniae is healthy children up to 40% carry strep pneumoniae as normal carriage. Now, coming to Mycoplasma PCR, that's again another problem, that you can have colonization with Mycoplasma in the upper respiratory tract. So even if PCR comes positive, ultimately you need to still correlate clinically if it is fitting. IgM can remain positive for several months together. So unfortunately, this is a global dilemma, that we really do not have a very reliable test to say, yes, if this is positive, this is Mycoplasma. It's always, again, kindly correlate clinically.
Yeah. So something similar. So I want to ask us a question about this BioFire in emerging respiratory tract. We even spoke about adenovirus, and just a couple of years back, we had a lot of cases of adenovirus. So, what is the role of BioFire in emerging respiratory tract infection? As you mentioned, it is more for viral, but then in given cases, especially in infants who come to us with respiratory infections like bronchiolitis, etc. So in all those cases, should we go ahead and do the BioFire?
See, adenovirus has kind of adenovirus. It defeats the principles that we follow for diagnosing viral infections, in the sense that we have seen adenoviral children looking sick. We have seen that inflammatory markers are very high. We have seen leukocytosis is usually associated with adenovirus. And sometimes it becomes difficult to not give an antibiotic in a child who's suffering from at least the little more severe forms. We have had adenoviral fevers going on for 10 days or more, requiring hospitalizations. So in those children, we have, I can only give our personal experience, that when we have got adenovirus positive, and we were reasonably sure to stop antibiotic in those children. But at the same time, even if you have co-infections are something that is not easily captured on these nasopharyngeal swabs. So if you, again, a clinical thing will decide. Mycoplasma is also known with co-infection. But what should not happen is, suppose you have detected adenovirus, please don't give oseltamivir. If you have, we have seen that you detect, you do expensive tests, but recommendations are not followed despite you do or you do not do. So that is a problem, that if you have influenza not so sick, why do you need to add on antibiotic? Because it's not like every influenza has a co-infection. So a lot of these things can help guide, I think. But not for OPD practice in general, maybe for hospitalized children.
So, Dr. Samir, are there any questions in the chat box further? Because we are running short of time. I would...
No, I don't think so.
Okay. So I'll just make it short now, because in the interest of time, Madam, though we had a very good video on antimicrobial resistance, these articles were there in the recent September 2024. So a quick comment on, or I would say a quick message for we practicing pediatricians on usage of antibiotics in routine practice, OPD as well as indoor.
Yes. So we know that antibiotics, specifically since you have put this on the slide, there is a lot going on internationally. The government, all top leaders had met last month, and the commitment is that we'll kind of increase our access use of antibiotics. What I mean is that all antibiotics have been classified by WHO into 3 groups: access, watch, and reserve. So what is generally recommended as first line for our day-to-day practice, whether it is amoxicillin, co-amoxiclav, these are first and second generation cephalosporins. These are basically recommended by all guidelines as first line for OP practice, and the consumption in your day-to-day practice should increase because they are aiming for a national total consumption of 70%. The other group is watch. Watch is basically, they have these third generation cephalosporins, carbapenems, and we have vancomycin also in that group. Azithromycin is in that group. What is watch is they have high potential to develop resistance. So we should be very judicious, extremely judicious. Not that you don't be judicious for access, but extremely judicious because they can become resistant soon. And reserve are those antibiotics which should be kind of used only if there is no other alternative. So antibiotics such as polymyxin, tigecycline, linezolid, these fall into reserve. So please, please, please do not use reserve antibiotics in OP practice unless there is no other alternative, and or even for that matter, IP practice, and use basically all antibiotics judiciously. I hope I was quick because I've been
Yes.
probably
Yes.
talking too much. Yeah.
I'll just add 2 sentences to what Danya said. Danya talked about which antibiotics to use. I am coming one step before that. Let us all make a habit to ask ourselves, do I need to use an antibiotic? For which we need to differentiate between viral and bacterial infections. So let us try and develop that confidence to differentiate. And mind you, if I am one day late in starting an antibiotic in a OPD case, no harm is done. Let me be sure I am dealing with a bacterial infection before starting an antibiotic. And finally, this worry that something will go wrong and things will get complicated is usually without any much basis. So as long as you and I are confident clinically, we will not go wrong. So first ask ourselves the question, do I need an antibiotic? And then comes what Dhanya said about the 3 classes of antibiotics.
Yeah, I think these messages are loud and clear. I don't want to repeat it in the interest of time, but I think we should have this background information of uh, emerging and re-emerging infection in mind and have a high index of suspicion. And with this clinical background, we should be very judicious in deciding what investigations are needed. And definitely, as far as antibiotics are concerned, first we should ask ourselves whether it is really needed or not. I think
I
we
would
will end
invite
this.
the audience to ask any
Yeah,
questions if they want to ask.
And Kasla sir, you can stop screen sharing if possible.
yeah. I will.
I'd like to just say something about this antimicrobial resistance, and the second last slide that you showed, Rajesh bhai, and how Dr. Danya absolutely brilliantly explained it, what the experts are doing and how it's going across the world. But the point is, at the end of the day, it is a ubiquitous problem. It is pervasive, and it is our own colleagues who are doing it. So in a way, just like the breastfeeding campaign and the anti-bottle feeding or the formula feeding succeeded not just because of legislation or policies, there's also a drive within pediatricians to self assess and peer monitoring. And sometimes they probably overdid it. We probably didn't like sometimes, but I think that monitoring, peer monitoring, was a very important aspect of success in achieving that to whatever extent we have achieved. Now, antimicrobial resistance seems to be a more serious problem. And that's why this kind of, I won't say policing, but at least peer monitoring may be important. I don't know what you all think about it.
Many angles, Samir. So, as what you said is right. But I think one of the most important things is that we need to have confidence in
Yes,
ourselves that I am looking at a viral infection and nothing will go wrong if I wait till tomorrow and reassess tomorrow. This is where more than half of us are faltering. We are worried कि अरे कल कुछ हो जाएगा तो, and that's where we are going wrong.
correct.
So I think it's a very well taken take-home messages by Kasla sir, Samir sir, and Chukhani sir, and of course Dr. Dhanya as well to give us. I'll like to thank Dr. Kasla sir for taking the whole session so seamlessly with a case-based discussion, so very well conducted, and of course our expert Dr. Dhanya and Dr. Chukhani sir to giving us in-depth discussion of each cases. A big thank you to our convener Dr. Samir Dalway sir. He's the visionary who has brought these two sessions again back again so that people can ask further, discuss about it who have missed it in the conference. And I think sir is a perfect visionary and a perfect candidate for our president elect position for 2025. Thank you so much, sir, for this session. And of course, we are looking forward to one more session in the next 15 days, which will be on pediatric endocrinology session. Again, a takeaway from the conference itself. We'll soon give the flyers for the same and the dates would be announced. There is, in the same, I'll also announce that there is on this Sunday, we have a respiratory viral infection module, which is at Hotel Park View, Andheri. The registrations are quite good and there are only few seats left. So if you are the one who want to still attend it, please do register. And we will hope to see you all on Sunday as well. Anything else you would like to say, Samir sir?
Thank you so much, Rajesh sir. Thank you very much, Rajesh Kasla sir. Adanya ma'am, thank you so much.
Thank you.
Thank you.
And thank you to all the wonderful audience
Yes.
who have. See, they don't go by the fact that there were 38 people or 40 people. These are 40 people who have resisted the temptation of attending Brian Adams. And they chose Rajesh Chokhani and Dhanya Dharmapal over Brian Adams. So, I mean, no doubt they are also great people. But imagine today, I think it is the biggest
These
feather in
people
the
will go
cap.
to Goa to see Brian Adams.
Rajesh Kasla, Rajesh Chokhani and Dhanya are more important than Brian Adams. Let us
Absolutely.
not forget this.
Thank you. Thank
Thank
you
you.
everyone for
Thank you.
joining in and hope to keep seeing you all at other scientific sessions. Thank you everyone.
Thank you so much, everyone. Good night.
Thanks.
Thank you.
Right
Thank you.
next door to our house at this Nesco ground. He's still performing.
Okay.
Thank you. Thank
Thanks.
you.
Bye.
Good night.
Bye.
Good night.
चलो, thank you, Rajesh भाई. बात करते हैं बाद में.
अच्छा